Today, we're going to delve into a fascinating and critical topic in human anatomy, joints. This lecture material, originally prepared by Professor Vanessa, provides a comprehensive overview of how our bones connect, allow movement, and function within the broader skeletal system. Joints, also known as articulations, are essentially where two bones meet. They are fundamental to our ability to move, but it's important to remember that with increased mobility, there is often a corresponding loss of strength. The structure of a joint is what ultimately determines its function. Let's begin by understanding how we classify joints. There are two main schemes for this: structural and functional. The structural classification is based on the anatomy of the joint, essentially what materials hold it together. The functional classification, on the other hand, considers the joint's range of motion.
Looking at structural classification, we have several categories. First, fibrous joints are held together by dense fibrous connective tissue or a fibrous ligament. Examples include sutures, which are the joints between the bones of the skull, gomphoses, the joints between a tooth and its bony socket, and syndesmoses, where bones are connected by a ligament, such as the distal joint between the tibia and fibula in your lower leg. Next, we have cartilaginous joints, which are held together by cartilage. These include synchondroses, which are rigid cartilaginous connections like the vertebrosternal joint of the first rib, and symphyses, where bones are connected by a pad of fibrocartilage, such as the pubic symphysis. Then there are bony joints, or synostoses. These are rigid, ossified joints where two bones fuse completely, and the boundary between them disappears. Good examples are the epiphyseal lines in mature long bones and the point of mandibular fusion in the jaw. Finally, the most mobile structural type is the synovial joint, which is enclosed by a capsule filled with synovial fluid. Your knee joint is a prime example of a synovial joint.
Now, let's consider the functional classification, based on how much movement a joint allows. Synarthroses are immovable joints. They can be fibrous, cartilaginous, or bony, and examples include sutures, gomphoses, synostoses, and synchondroses. Then there are amphiarthroses, which are slightly movable joints. These can be fibrous or cartilaginous, like syndesmoses and symphyses. And finally, diarthroses are freely movable joints. All synovial joints fall into this category.
Let's dive deeper into synovial joints, as they're the most common type for significant movement. These diarthroses are freely movable joints typically found at the ends of long bones. They're surrounded by a joint capsule, also called an articular capsule, which is continuous with the periosteum of the bones. This capsule has an inner synovial membrane and an outer fibrous capsule. The synovial membrane produces synovial fluid, which fills the joint cavity. Crucially, articular cartilage covers the articulating surfaces of the bones within the joint, preventing direct bone-on-bone contact. Synovial fluid itself is a clear, viscous solution similar to interstitial fluid, but with a high concentration of proteoglycans, particularly hyaluronin. You'll find it in small amounts within joints, and it serves three primary functions. First, lubrication between articulating surfaces, reducing friction. Second, nutrient distribution for the chondrocytes, the cartilage cells within the articular cartilage. And third, shock absorption, cushioning the joint when it's subjected to compression. Synovial joints also have several important accessory structures that protect and stabilize them. These include cartilages, like the meniscus, which is a fibrocartilage pad found between opposing bones, and fat pads, localized masses of adipose tissue covered by the synovial membrane that protect articular cartilages and pack the joint space. Ligaments are also critical. They support and strengthen joints. They can be extracapsular, meaning outside the joint capsule, or intracapsular, inside the joint capsule. When a ligament is partially torn, we call that a sprain. Other accessory structures include tendons, which attach muscles to bones and help stabilize the joint, and bursae. Bursae are small pockets filled with synovial fluid that reduce friction and act as shock absorbers, cushioning areas where tendons or ligaments might rub. Inflammation of a bursa, often due to repetitive motion, pressure, infection, or trauma, is known as bursitis, and it results in swollen bursae with excess synovial fluid. Several factors contribute to the stability of synovial joints, preventing injury by limiting their range of motion. These include the collagen fibers of the joint capsule and other ligaments, the shapes of the articulating surfaces themselves, the presence of menisci, and other bones, muscles, or fat pads surrounding the joint. Finally, the tension in tendons attached to the articulating bones also plays a significant role in joint stability.
Now, let's explore the movements possible at synovial joints. We define range of motion as the full extent of movement possible at a particular joint. We also classify joints by their axes of motion. A monaxial joint permits movement around one axis, like your elbow. A biaxial joint allows movement around two axes, such as your wrist. And a triaxial joint permits movement around three axes, like your shoulder. We see various types of movement at synovial joints. Gliding movement occurs when two flat surfaces simply slide past each other, like between your carpal bones. Angular movements change the angle between articulating bones. These include flexion, which decreases the angle in the anterior-posterior plane, extension, which increases that angle, and hyperextension, which extends beyond the normal anatomical limit. Other angular movements include abduction, which is movement away from the body's longitudinal axis in the frontal plane, and adduction, which moves toward that axis. Circumduction is a complete circular movement without rotation, like moving your arm in a circle. Rotational movements involve rotation in reference to the anatomical position, such as rotating your head left or right. Limb rotation is relative to the body's longitudinal axis. This includes medial rotation, an internal rotation toward the trunk's longitudinal axis, and lateral rotation, an external rotation away from it. Specific to the forearm, pronation rotates the forearm so the radius rolls across the ulna and the palm faces posteriorly, while supination turns the palm anteriorly.
Then we have special movements that occur at specific joints. These include inversion, twisting the sole of the foot medially, and eversion, twisting it laterally. Dorsiflexion is flexion at the ankle, essentially lifting your toes, while plantar flexion is extension at the ankle, like pointing your toes. Opposition is the movement of your thumb toward your palm or other fingers, and reposition returns the thumb and fingers from opposition. More special movements include protraction, which is moving a body part anteriorly in the horizontal plane, or forward, and retraction, its opposite, pulling back. Depression moves a structure inferiorly, or down, while elevation moves it superiorly, or up. And finally, lateral flexion involves bending the vertebral column to the side.
Synovial joints are further classified by their shapes. Plane joints or gliding joints have flattened or slightly curved surfaces that slide against one another, offering limited, non-axial gliding motion, such as the intracarpal or vertebrocostal joints. Hinge joints permit angular motion in a single plane, making them monaxial. Your elbow, knee, and interphalangeal joints are examples. A condylar joint or ellipsoidal joint features an oval articular face nested within a depression on the opposite surface. These permit biaxial angular motion, like the radiocarpal joint in your wrist. Saddle joints have articular faces that fit together like a rider and a saddle, also allowing biaxial angular motion, such as the first carpometacarpal joint of your thumb. A pivot joint permits monoaxial rotation, like the atlantoaxial joint between your first two cervical vertebrae. Lastly, ball and socket joints have a round head of one bone fitting into a cup-shaped depression in another. These are triaxial, permitting angular movement, circumduction, and rotation, and include your shoulder and hip joints. Moving to a specific region, let's examine the intervertebral joints of the vertebral column. These are the joints between adjacent vertebral bodies and their articular processes. The first two cervical vertebrae form a pivot diarthrosis synovial joint, the atlantoaxial joint. The adjacent articular processes are connected by plain diarthrosis synovial joints, and the adjacent vertebral bodies are connected by symphysis.
Between the vertebral bodies, we find intervertebral discs, which are fibrocartilage discs. Each disc has an outer layer called the annulus fibrosus, a tough fibrocartilage ring that attaches the disc to the vertebrae. Inside, there's a soft, elastic, gelatinous core called the nucleus pulposus, which acts as a shock absorber. Vertebral end plates made of hyaline cartilage and fibrocartilage cover the superior and inferior surfaces of the disc. Damage can occur, leading to a bulging disc, where the annulus fibrosus bulges into the vertebral canal, or a herniated disc, where the nucleus pulposus breaks through the annulus fibrosus and compresses spinal nerves. Several intervertebral ligaments also play a crucial role. These ligaments are attached to the bodies and processes of all vertebrae, binding them together and stabilizing the vertebral column. Examples include the ligamenta flava, which are paired ligaments connecting the lamina of adjacent vertebrae, the posterior longitudinal ligament connecting the posterior surfaces of vertebral bodies, and the anterior longitudinal ligament connecting the anterior surfaces of vertebral bodies. Further ligaments include the interspinous ligaments connecting the spinous processes of adjacent vertebrae, and the supraspinous ligament, which connects the tips of the spinous processes all the way to the sacrum and is continuous with the ligamentum nuchae up to the skull. The vertebral column allows for several movements: flexion, bending anteriorly; extension, bending posteriorly; lateral flexion, bending to the side; and
Next, let's look at two prominent joints, the elbow and knee joints. The elbow is a complex hinge joint involving the humerus, radius, and ulna. Specifically, the humero-ulnar joint between the trochlea of the humerus and the trochlear notch of the ulna is the largest and strongest joint at the elbow. There's also the humero-radial joint between the capitulum of the humerus and the head of the radius. The elbow joint is remarkably strong due to several factors. The bony surfaces of the humerus and ulna interlock securely. A single, thick joint capsule surrounds both the humero-ulnar and the proximal radio-ulnar joints, and strong ligaments reinforce this capsule. Key elbow ligaments include the radiocollateral ligament, stabilizing the lateral surface, the annular ligament, which binds the head of the radius to the ulna, and the ulnar collateral ligament, stabilizing the medial surface. The knee joint is another complex hinge joint involving the femur, tibia, and patella. Its primary function is to transfer weight from the femur to the tibia. It has three articulations, two between the femur and the tibia at the medial and lateral condyles, and one between the patella and the patellar surface of the femur. The knee's joint capsule is thin and partially incomplete. It features medial and lateral menisci, which are fibrocartilage pads at the femur-tibia articulations that cushion and stabilize the joint laterally. Fat pads and bursae also provide cushioning and reduce friction here. The knee is supported by 7 major ligaments. The patellar ligament is continuous with the quadriceps tendon and keeps the patella in place, supporting the anterior surface. 2 popliteal ligaments between the femur and the heads of the tibia and fibula support the posterior surface. Inside the joint capsule, we find the anterior and posterior cruciate ligaments, often called the ACL and PCL.
These attach the femur to the tibia and are crucial for limiting anterior and posterior movement. Finally, the tibial collateral ligament, also known as the medial collateral ligament, and the fibular collateral ligament or lateral collateral ligament, reinforce the medial and lateral surfaces of the knee joint, respectively, stabilizing it when fully extended. Let's move on to the shoulder and hip joints. The shoulder joint, or glenohumeral joint, is a ball and socket diarthrosis between the head of the humerus and the glenoid cavity of the scapula. It boasts the greatest range of motion of any joint in the body, but consequently, it's also the most frequently dislocated. Its stability comes from surrounding skeletal muscles, tendons, and ligaments. The joint capsule of the shoulder is loose. The glenoid labrum, a rim of fibrocartilage, extends beyond the bony rim of the glenoid cavity, deepening its socket. The acromion and coracoid process of the scapula project laterally, superior to the humerus, and provide additional stabilization. Key shoulder ligaments include the acroclavicular ligament, supporting the superior surface, the coracoclavicular, coracoacromial, coracohumeral, and glenohumeral ligaments. A shoulder separation specifically refers to a partial or complete dislocation of the acroclavicular joint. The muscles of the rotator cuff, the supraspinatus, infraspinatus, teres minor, and subscapularis, along with their tendons, reinforce the shoulder joint and limit its range of motion. Several bursae, such as the subdeltoid, subcoracoid, subacromial, and subscapular bursae, are also present, reducing friction.
In contrast to the shoulder, the hip joint is a strong ball and socket diarthrosis, formed between the head of the femur and the acetabulum of the hip bone. It permits flexion, extension, adduction, abduction, rotation, and circumduction. The acetabular labrum, another rim of fibrocartilage, increases the depth of the joint cavity and helps seal in synovial fluid. The hip joint is also supported by powerful ligaments. These include the iliofemoral ligament, a thickening of the capsule between the ilium and the femur, the pubofemoral ligament, a thickening between the pubis and the femur, and the ischiofemoral ligament, a thickening between the ischium and the femur. The transverse acetabular ligament fills a gap in the inferior border of the acetabulum, and the ligamentum teres, or ligament of the femoral head, attaches the acetabulum to the femoral.
Now let's discuss the effects of aging on joints. We often see degenerative changes. Rheumatism refers to pain and stiffness affecting the musculoskeletal system broadly. Arthritis is joint inflammation with several forms. Osteoarthritis, or degenerative joint disease, is caused by wear and tear on joint surfaces or genetic factors affecting collagen formation, commonly affecting people over age 60. Other forms include rheumatoid arthritis, an autoimmune disease where the immune system attacks joint tissues, causing inflammation. And gouty arthritis results when uric acid crystals form within the synovial fluid, most often affecting the metatarsal phalangeal joint of the great toe. Degenerative changes can also stem from joint immobilization, which reduces the flow of synovial fluid. This can sometimes be treated with continuous passive motion, or CPM. As we age, the risk of fractures and dislocations increases because bone mass decreases and bones generally weaken. Finally, let's consider the functional relationships between the skeletal system and other body systems. Our living bones are constantly undergoing remodeling, a dynamic process involving bone formation by osteoblasts and bone resorption by osteoclasts. The balance between these two processes depends on factors like age, physical activity, hormone levels, the availability of calcium and phosphorus, and genetic and environmental influences. The skeletal system interacts closely with many other systems. Muscles, for instance, attach to bones, allowing movement. Bone growth and maintenance are tightly controlled by the endocrine system. The skeletal system is also crucial for producing blood cells and platelets for the cardiovascular system. Our digestive and urinary systems provide the necessary calcium and phosphate minerals for bone growth.
Essentially, the skeleton serves as a vital reserve for calcium, phosphate, and other crucial minerals.
This concludes our deep dive into the intricate world of joints, drawing from Professor Vanessa's comprehensive lecture material. Understanding these structures is key to appreciating the mechanics of our bodies. If you found this discussion informative, consider sharing it with someone curious about how our bodies move.